Hi, my name is Dr. Jeff Moscow, and I'm a gastroenterologist and advanced endoscopist here at St. Michael's Hospital. With the role of fit testing in Ontario underway, it is my pleasure to partner with Cancer Care Ontario in reviewing an approach to the resection of colorectal polyps 2 centimeters or less. Colorectal polyps and flat lesions less than 20 millimeters in size constitute 95% of all colorectal neoplasms and therefore make up the majority of resections performed by colonoscopists. The risk of cancer in lesions less than 5 millimeters is negligible, is far below 1% in lesions 6 to 9 millimeters, and is about 1 to 2% in lesions 10 to 19 millimeters in size. The vast majority of benign lesions less than 20 millimeters, with the exception of certain lesions extending into the appendix or terminal ileum, are endoscopically resectable, with lower risks and costs than surgical resection. Referral of benign lesions less than 20 millimeters for surgical resection is a problematic use of resources in Ontario and puts patients at unnecessary risk. Thus, colonoscopists must be proficient in the safe and effective resection of these lesions. If lesions in this size defy resection, they should be referred to a center with expertise in endoscopic resection and not to surgery. What do we know? Well, we know that FIT-positive colonoscopies will yield more advanced adenoma. Advanced adenomas are lesions with high-grade dysplasia, are greater than 10 millimeters, and or have a villus component. This is clearly shown in the Alberta data, whereby FIT-positive colonoscopies detected more cancers as well as more screen-relevant lesions. We also know that a significant number of colonoscopists have never received formal polypectomy training. There is also emerging data revealing that incomplete polyp resection leads to post-colonoscopy colorectal cancer, so-called interval cancers. Current colonoscopy quality metrics like withdrawal time and ADR also do not seem to correlate with polypectomy competency. Finally, in spite of our best efforts, 10% of polyps between 5 to 20 millimeters are incompletely removed. Just like anything in medicine, it is imperative that we have an approach to polyp resection, no matter what the size of the lesion is. While many experts approach polypectomy differently, this is our approach here at St. Michael's Hospital. I recommend starting with optical diagnosis. Using a combination of the Paris classification, location, granularity, and pit pattern helps determine the risk of submucosally invasive cancer. In lesions with invasive cancer, resection should not be attempted. In all other lesions, you then have to decide if the lesion is resectable by you during that session with the equipment available to you. You have to consider your access to the polyp and where gravity is in terms of where fluid and or blood may pool. You then need to have a plan B, C, and D if things aren't going quite as planned. What if there is significant bleeding? Are you equipped to deal with a deep mural injury? You will need to decide if you are going to inject the lesion, what to use as your injectate, how to plan to remove it, and what to do with the defect afterwards. We will be reviewing a number of these considerations through this multi-part series. It is important to have modern and appropriate equipment available to you to ensure safe and effective resection of lesions. High-definition colonoscopes are considered the standard of care in 2019 and are necessary to optimize lesion detection and evaluation. They have the capacity for optical zoom and digital chromoendoscopy, which help to identify lesions with possible submucosal invasion. In this video, you are seeing the Olympus 190 series and the use of narrowband imaging. Snares come in many shapes and sizes with differing wire type and size, shape, rigidity, and size. Monofilament wires offer faster transection and so are better for cutting versus braided snares, which are better for conducting electrosurgical current. Thicker wires provide slower cutting versus thinner wires. Most snares are medium rigidity. Some cold snare only and specialty options offer increased rigidity to minimize slippage of the mucosa, thereby ensuring negative margins. The many different shapes and diameters allow endoscopists to choose both what they are most comfortable with, but also what suits the lesion they are resecting. While most units will only carry a small number of options, in an ideal world, we should pick the type of snare we want based on our approach. For cold snare polypectomy, we want a small diameter, stiff, thin wire snare. For hot snare EMR, we often use braided, medium diameter wire snares. Do you know your generator? There is a significant difference between the newer microprocessor-controlled constant voltage generators versus the older constant power ones. Here, using a surgical loop, the constant voltage generator at 300 watts delivers only the necessary power by sensing the voltage between the active electrode and the tissue in real time through an internal high-speed sensor circuit and continuing to maintain the current voltage setting through instantaneous feedback. Consistent incision and coagulation depth can be maintained with high reproducibility. This is in contrast to the constant power generator, which delivers what it is set to, even when tissue and/or surface area doesn't need that type of power. There are many variables affecting the desired tissue effect during endoscopic resection. Endocut is an IRBI-specific, with the IRBI-VIO 300 shown here, fractionated cutting waveform. It uses patented algorithm capable of recognizing spark production. It consists of an alternating pure cut and soft coag current. With this waveform, multiple variables can be set by the endoscopist: hemostatic effect, cut duration, and cut interval. These can all be found on the ESU user interface. Increasing the effect changes the amount and type of coagulation that occurs between cut cycles. It ranges from no coagulation to soft coag to forced coag. Cut duration refers to the time within the cycle spent delivering the cut current. Cut interval determines the time between on cycles. Endocut Q is the waveform of choice for snare polypectomy and EMR. It uses slightly higher voltages, higher cut interval, and lower cut duration. In comparison to other blended currents, Endocut seems to produce more controlled cutting with less thermal insult. Thanks for your attention. Stay tuned for part 2, where we will discuss polyp inspection, optical diagnosis, and pre-polypectomy preparation.